Now I'll introduce Dr. Terry Lee, who is a child and adolescent psychiatrist and an assistant professor in the Department of Psychiatry and Behavioral Sciences at the UW School of Medicine. He's interested in the development and dissemination of evidence-based practices in mental health treatment for high-needs youth, particularly those who are involved in the juvenile justice system or the foster care system. And he currently provides psychiatric services for youth in King County juvenile detention, on the Washington State Juvenile Rehabilitation Administration, the JRA, as well as to the Primetime Project, which is a modified MST program serving African American youth who have co-occurring mental health and substance use disorders who are involved in the juvenile court system. He also chairs the Washington State JRA Psychiatry Quality Improvement Committee and supervises trainees in the UW residency program that rotates at Echo Glen, the Children's Center. And he is a consultant to the Harborview Foster Care Assessment Program and the Family Integrated Transitions Program, and is involved with the Partnership Access Line, which is a Washington State Legislature-funded clinical and evaluation project providing child psychiatry consultation to primary care providers. You must be tired. That's a lot of work. So I'm really delighted to have Dr. Terry Lee here today. Please join me in welcoming him.
Well, we'll get set up here. I think we're a small enough group where I might try to get to know who you are. So how many people here are clinicians? How many are students? Let's see, who else am I missing? Researchers? And what else?
Yeah, some faculty.
Wraparound.
What?
Wraparound.
Wraparound? Okay.
Training and development.
Okay. Great. All right, well, I'm going to talk today about pediatric bipolar disorder. I have a lot of slides, probably too many slides, so I'm going to go fast, but if I say something that that I don't make sense, which my wife tells me I do a lot of the time, please interrupt me, yell out, raise your hand, and I'll try to clarify. And again, these slides will be posted, so we can refer to them later. So these are the goals. We're going to talk about what are the factors contributing to the increased diagnosis of pediatric bipolar disorder. We're going to talk about the clinical presentation. We're going to talk about the longitudinal course, at least what we know about these kids who've been diagnosed and following them through time, how they present. We're going to look at medication response and some future directions for where we seem to be with pediatric bipolar disorder today. So again, this is a very controversial topic. Say that over and over. But something else I'll be saying over and over is that regardless of what we diagnose these kids with or what we call these kids, it's very clear that they present with very concerning behaviors and symptoms, and families are in great need of help. So what's bipolar disorder? It's a DSM diagnosis, also known as manic depressive illness, and it's characterized by episodes of highs or mania and lows, depression. And the episodes represent a change from baseline. So I made a little mood chart here. Because I don't have a pointer. Okay. So this is euthymia, so neither depression, just kind of feeling okay. Mania, elevated mood, and depression, low mood. So with no mood disorder, someone would kind of have some highs and lows, but it wouldn't persist, it wouldn't be too extreme, it wouldn't go too high or low over time. So in bipolar disorder, you get highs, mania, elevated mood, racing thoughts, and then a return to baseline. And this persists. So there's like an episode of mania, then you return to baseline, and then this would be an example of going to an episode of depression. And again, a return. These are the DSM criteria for mania. This is abbreviated. Again, you have this in DSM, so you can review it more carefully, but the idea is it's a distinct period of elevated mood lasting for at least 1 week. These are some of the symptoms. Increased self-esteem, rapid pressured speech, flight of ideas, engaging in high-risk behaviors, spending a lot of money, for instance, or engaging in increased sexual high-risk behavior. But you can say these things, but here's a little example with a disclaimer. So this is something I just downloaded. I don't know what's going on. Maybe this person just did this for entertainment's sake. I don't know that this is really a manic episode, but in kind of looking around for something, I thought this actually features a lot of the characteristics. again, I'm not sure what this woman actually has, but it kind of features a lot of things we talked about. So high energy, loud, pressured speech, elevated mood, kind of a disorganization in her thinking. Okay, and again, you can't just watch a clip for 1 minute and say this person has mania. This could be due to methamphetamine or cocaine use, and also for mania, you'd really want to see these symptoms for days or weeks. Okay, untreated, you'd really look like this for weeks, not just for a few minutes. Okay. So part of the controversy is that in less than a 10-year period, there was a 40-fold increase in the rate of diagnosis of bipolar disorder in children. 40-fold, 40. Okay, and it was a doubling for adults. So there's something that happened in our country whereby the criteria seem to be loosened, especially for children. It's just what it looks like in a graph. And so what are some of the reasons offered in support that this is valid? So one is that whatever is being called pediatric bipolar disorder, these symptoms are stable, at least as far as long-term studies, as good as we have, like for 8 years. We'll talk a little bit about this, that whatever symptoms these are that these kids have, they seem to persist over time. But again, that's not earth-shattering, right? The best predictor of future behavior is past behavior. Also, when you do studies of adults with bipolar disorder and ask them about their childhood, there's just one study, but high percentages of them will say, I first had symptoms of bipolar disorder before I turned 18. And again, in this study, about 30% reported symptoms before the age of 13. Again, in support of this loosening up the criteria for adults, some adult researchers are saying that there are, in fact, adults being diagnosed with bipolar disorder who have shorter episodes of mania and hypomania. There was also a book called The Bipolar Child by Dimitri Papalos. This is in the 3rd edition. His wife is co-author in the 3rd edition. And so this is like the Bible of pediatric bipolar disorder. They have a website. There's a foundation set up. They've had 500,000 hits or something to their web series. They've had like 500,000 hits to the web series. So again, this is really it's really helped things catch on with bipolar disorder. So Dimitri Papalos is an adult psychiatrist and geneticist, and he was looking at some kids of adults with bipolar disorder, and he described some fairly non-specific symptoms of irritability, sleep problems, aggressiveness, lying, this type of thing. So this didn't look like adult bipolar disorder, but this was correlated with kids whose parents had bipolar disorder. Again, you can look at their website, and they have all sorts of materials, checklists and things like this, as well as support and education. It's also the effects of pharmaceutical companies. So again, I'm not maybe I do like conspiracies, but this is a big market. Okay, when you look at antipsychotic medications in the United States, these are the top revenue class of medications in the United States, more than high blood pressure medications or anything else. So according to the Times, in 2009, it's like $14.6 billion spent on antipsychotic medications. To be clear, this isn't just for kids. The adult market is also very large. It's been expanded. And geriatric nursing home populations also, that's like another target for marketing. And there have been some settlements for fraudulent marketing. And so these, again, is just an example of some of the fines that were paid. So again, the first one, AstraZeneca, $520 million settlement. But of course, they had over $20 billion worth of sales of their product, Seroquel, in a 12-year period. And this is ongoing. Then there's also the relationship between psychiatrists and pharmaceutical companies. I'm not going to say too much about this. I don't want to appear too snarky or gossipy, but I mean, this is not this is not a pretty thing. So again, you can Google this on your own, but there clearly there were psychiatrists that have received a lot of money from pharmaceutical companies, and how can we assess what the effect of this has been? Then there were issues within DSM itself from psychiatry. So in DSM-3, you needed to have manic symptoms for 7 days to make a diagnosis of mania. Where did the 7 days come from? Well, was there research to support that? It was probably more expert consensus. So in DSM-3R, the 7-day requirement was removed. And DSM-3R made no reference to how long you had to be manic to be diagnosed with mania or bipolar disorder. And so this was associated with a great increase in the prevalence of the diagnosis of bipolar disorder, again in adults as well as kids. So in DSM-4, the 7-day requirement was reinstated. And then there's a debate as to how long the 7 days. Does that mean continuous? It's like this woman on the videotape, symptoms like that for 7 days, or could you have like these brief episodes of mania, like for like 15 minutes at a time, and then it adds up to 2 to 4 hours a day for 7 days in a row? And there are some people that have interpreted it that way. So let's talk about some of these kids. So here's an article from 1995. Janet Wozniak is at Harvard, Massachusetts General. Joseph Biederman is also one of the co-authors of this paper. And they start out this title, Mania-like symptoms suggestive of childhood onset bipolar disorder. They've become much more assertive over time, not saying that it's not just suggestive, but these kids in fact have bipolar disorder. But this is one of the first groups of kids to be characterized. So kids in a clinic, 43%, or 43 total, met criteria for mania based on a structured instrument. And interestingly enough, of these 43, 42, or almost all of them, also met criteria for ADHD. So again, this is a little different than adult bipolar disorder, right? So you're saying all these kids with bipolar disorder, most of them have ADHD. And then the average onset of mania was at age 5.4 years old. Try to wrap your head around that. And while you're doing that, that 70% of the parents reported that the age of onset for their kid was actually before the age of 5. So we're talking about preschool bipolar disorder, right? Now, some of you are laughing, and I'm glad you can laugh because it's kind of sad that we went this direction. And 84% with mixed mania and depression within the same day. So it's a mixed type, again, not episodes of mania with a return to baseline. It's really mixed, what they called mood of depression and mania in the same day. For another group, Barbara Geller at Washington University in St. Louis, a little later, they also started describing some of these kids. So this is a group of 93 outpatients, average age onset 7, okay, so a little better than 5, but we're still talking about very young kids being diagnosed with bipolar disorder. Again, the mean episode duration was 3.5 years. So their mood episode of mixed mania and depression lasted for 3.5 years. Again, a little hard to understand, but not really a return to baseline. 87% with comorbid ADHD. So just like the Mass General group, almost all these kids that were being diagnosed with bipolar disorder also had comorbid ADHD based on a structured instrument. Now, Geller, the group, do go on to try to differentiate and say, well, this is like an overlap. Of course, you get a mistake like hyperactivity for increased levels of activity. And they publish a lot on what are the real criteria for pediatric bipolar disorder. Yes?
Oh, no, I wasn't.
Okay. What are the real criteria, but I'm not sure that that's really going anywhere.
So actually, that's a good point, because that's what we keep running into. Mm-hmm. People saying is that ADHD or pediatric bipolar.
Right.
Wasn't one of the studies done at an ADHD clinic? I forget who it was. And almost all the kids qualified for pediatric bipolar. Mm-hmm. So he was saying that most all misdiagnosed.
Right. There are people that purport that, in fact, these kids don't have ADHD. They have bipolar disorder. Again, why is that important? It would have a lot of repercussions for, like, what can the parents expect in the future? What medications should you use? Again, just to jump to the punchline, since I don't have this in my slides, if you take these kids with bipolar disorder and give them stimulant medications, in fact, their ADHD will get better, and their bipolar disorder does not become worse. Because if you took an adult with bipolar disorder and put them on stimulants, put them on amphetamines, they would generally get worse. Okay. So again, this mixed mania and depression, rapid cycling. The later study by Geller, again, almost all the kids had irritability, mixed mania, average of 3.5 cycles per day, of mania and depression, what they're calling mania and depression. Other people have since come to call chronic irritability, non-episodic irritability, and long. Again, these kids are ill. So kind of the summary then, these kids being diagnosed with pediatric bipolar disorder, they may not meet the criteria for bipolar disorder. They may not actually have manic episodes. They may not have depressive episodes. But they're clearly impaired as far as psychosocial functioning goes. Leibniz proposed a broad phenotype and a narrow phenotype, saying, well, there's this narrow phenotype that looks like adult bipolar disorder, and then there's this other, a broad phenotype where it's characterized by irritability, mood instability, reactivity. So instead of this, you can think of pediatric bipolar disorder, at least it was proposed to look something like this, where you're just going up and down all the time, and it's pretty chronic, and there's no return to baseline. So this makes the discussion of pediatric bipolar disorder very difficult, that you don't really know what kind of bipolar disorder some people are talking about sometimes, and they say, well, I evaluated these kids, that they had mania, they grew up, they had mania, and you're saying, well, is it this kind of mania, or is it this kind of mania? And so some psychiatrists have begun to refer to the classic bipolar disorder as Cade's disease. I'm going to call it classic bipolar disorder during this talk, but sometime you may, I'm not sure if this will take or not, but Cade was someone who reported on the effectiveness of lithium for bipolar disorder. Of course, there were probably earlier people who did this, but anyways, for whatever reason, some people have begun using the term Cade's disease just for clarity's sake and communication, that the classic type of bipolar disorder is Cade's disease, and there are these other kinds of bipolar disorder. So, is this a worldwide phenomenon? One question is like, wow, could there have been all these kids with bipolar disorder and we just didn't know it, or we were misdiagnosing this? There's a review article. United Kingdom, they had 0 cases of pre-adolescent mania, 0 cases of hospital-referred kids. Just to give you a flavor again, just in one study, 30% of all kids admitted to an inpatient unit in the United States were diagnosed with bipolar disorder. And they report other countries, again, this is low. Now these are including teens. Now there's no doubt that a kid who's gone through adolescence can present like an adult with bipolar disorder. So you get low rates, and some of these are probably teens that are presenting with classic bipolar disorder. Here was a book that was written, essentially talked to child psychiatrists in all these countries, and pretty much the conclusion is that prepubescent bipolar disorder is either non-existent or very rare in these other countries. So another question would be, again, is pediatric bipolar disorder continuous with classic bipolar disorder? So do these kids with chronic non-episodic irritability grow up to have classic bipolar disorder? So this was one study in Canada that, the author was reviewing 2 studies, or two groups of research, one in Canada and one in Holland. These are families where there's a lot of family members with bipolar disorder, then following their kids prospectively through time to see what would happen. And again, the bottom line is that none of the kids met criteria for bipolar disorder before the age of 12. And in the kids who grew up to have bipolar disorder, as adults, none of them were irritable, aggressive, or continuously cycling as kids. Okay? Well, again, it's possible that there's more than one pathway to become bipolar as an adult. But this was a high-risk group that were followed looking for bipolar disorder and symptoms of irritability. So this, something like Geller has got this tool that she's developed where if you're manic for 4 hours a day, usually in little bits, this seems to continue. There's one study she reported, but she's reported many times on how the kids continue to have this chronic moodiness and problems with psychosocial functioning. Another study, this is a 3-site study, again looking prospectively. So they diagnosed kids on the spectrum of bipolar disorder, and they followed the kids for 4 years and noted that during the follow-up period, the kids were symptomatic about 60% of the time. So again, a lot of symptoms, but they tended to be depression and moodiness, not true mania. Again, the kids had problems with functioning. Now, Labenluft had come up with this broad phenotype, and she also called it severe mood dysregulation, SMD. And again, you can think of the shorthand. The criteria have changed a little bit over time, but you can think of it as like chronic, non-episodic irritability. And so this was applied to the Great Smoky Mountains study. So this is an ongoing longitudinal study where it's epidemiological, so that they're just evaluating all the kids in public school, actually, and then that's how they entered, and that they're following them over time. So they went back and applied the severe mood dysregulation criteria to these kids, and then they've been able to follow them up to 18 and see what do they look like. And so the kids who had this mood dysregulation at 18, compared to control group, they were more likely to have depression, not bipolar disorder. There was one kid that developed bipolar 2 with the hypomania. There's another study with the Labenluft group. Again, they took 94 kids with narrowly defined bipolar disorder and 84 with broad phenotype. Followed them up for a little bit beyond 2 years, and this is what they found. So the kids with bipolar disorder, over half did develop manic symptoms, whereas what they were calling severe mood dysregulation, only one of them developed bipolar disorder, and that was bipolar 2 disorder. Again, there's no evidence that the chronic non-episodic irritability turns into adult bipolar disorder as far as we can tell. There's another study, again, looking at subsyndromal bipolar disorder, another epidemiological study. This study was also good in that people said, well, what is the actual prevalence of bipolar disorder in kids? It's actually in Oregon, about 1% incidence, mostly bipolar 2 and cyclothymia. So they had these other kids with not quite bipolar disorder and evaluated them again at age 24. What they found was elevated rates of depression, anxiety, and antisocial and borderline personality traits, but not an elevated incidence of bipolar disorder. Again, these challenging kids grow up to have other psychiatric symptoms. Again, you'd think it'd be very difficult to be impaired and have problems with emotional and behavioral control. But that would put you at risk for depression, anxiety, and possibly cluster B traits, but not bipolar 2. So there's some people say, well, I don't care what you call it, it's what you do about it that's important. So maybe they're different, maybe they don't grow up to have bipolar disorder, but since they seem to meet, at least under some people's interpretation, since they seem to have met criteria for bipolar disorder, maybe they'll respond to the same medications, right? So what's the response? There's some problems with extrapolating from medication response. First, most medications have pretty broad actions, and they're fairly nonspecific. Also, the response isn't great, and medications tend to treat symptoms. You also need to be clear on what criteria of bipolar disorder they use. So if you had a youth with Cade's disease or classic bipolar disorder, and you put them on lithium and they got better, you'd fully expect that to happen. But what about this more broad, chronic, non-episodic irritability? Do these kids respond to lithium or other mood stabilizers? The other problem is that, at least in the short term, kids with psychiatric issues, they have high rates of placebo response. So this is why you need to do randomized controlled trials. I mean, it's fine if you're trying to discover a new treatment. An open trial, a non-controlled trial is fine if you're trying to find something new, but before you're going to say something works, you better compare it to a placebo. There are just some placebo studies. So looking at depression, there's a meta-analysis of 12 studies, 12 good randomized controlled studies, and for childhood and adolescent depression, about half of kids will respond to a placebo, at least in the short run. You got that? Another single study looking at kids with depression with comorbid disruptive behavior disorders. So again, you think there's a pretty severe depression, right? That you not only are depressed, but you have these behavioral problems. You're trying to function in school and in society. In fact, in a single study, 2/3 of the kids with comorbid depression and conduct disorder and other disruptive behavior disorders, 2/3 of those kids responded to placebo, at least in the short run. Yes?
Can you explain why that is?
Well, there's a lot of thinking. I mean, you'd have to, there are a number of factors that you'd have to consider. One would just be, what's the spontaneous remission rate? Like, if you just don't do anything, how many people will get better with depression or depression with conduct disorder? So there's going to be a chunk of those kids that just would have gotten better had you done nothing. I don't think that's the bulk of it, because when you look at depression, it's a bad disorder, especially in kids. I mean, that people are ill and they tend to stay ill and get ill again. I think more so it's just something about when people think they're getting help, this will change their behavior. It may change the parents, like, oh, there's a chance he's getting help. Let's try a little harder on this behavioral stuff that people are talking about. Or maybe as a parent, gosh, he's in the study. Maybe I'll just try to help him a little bit with his depression. And then the kid himself or herself may say, well, I might be getting help, and what can the mind do when you think you're getting help? Yes.
Did any of these studies look at environmental factors like parenting, issues going on in the family, drug, alcohol abuse, anything else?
Yeah, that's been looked at, not to the degree probably that you would like, but that's been looked at. Now the Washington University group, their subjects are more of like a middle class family where the kids live with both their parents and things like that. But yeah, other folks have looked at is there higher incidence of say home issues and things like that. And right, and the other thing is that people might say, well, like lower SES, for instance, that may correlate, but you could also make the argument that stress brings on more psychiatric disorders. Yes?
These defining response rates, generally are they talking about what would be considered a positive response, or are they just talking about any detectable positive?
So whatever criteria were used, so for instance, this last one, which actually had to do with pediatric bipolar disorder, we'll talk about this study. About half the kids put on placebo with this bad behavioral and emotional disorder were felt to be responders. And in this study, they defined it as a 50% decrease on the Young Mania Rating Scale. And that was the definition of response that they went into the study using. And it's a common definition.
Yeah, that's a common definition.
Yeah. And of course, it's more complicated because you could have a 50% reduction, but you could still be very high and still be very symptomatic. But that was the criteria that was applied to the medication group as well. Yeah. Yes?
This is a little off, but roughly, do those placebo effects hang in there, or do they drop off?
They tend not to persist. Yeah, they tend to be short term. Okay. And you don't always do long-term studies. Again, you could say it's unethical to do a long-term placebo study because, especially if there's a known treatment, you can't have a group on placebo for a long period of time. Okay, so again, just knowing that and think of what effect this has. Think of your work for the clinicians in the group that the medication worked and then it stopped working. It could be that it stopped working, or maybe it wasn't the medication that was working to begin with. The same holds true for non-medication interventions too. We don't always do like a sham therapy, a sham psychotherapy when we do psychotherapy studies. Sometimes it's treatment as usual, but there was a study actually published in LA County showing that the kids that got help from the mental health center did about the same as the kids that weren't studied. Well, actually, this isn't a placebo response, but I'm sorry, this has to do more with the parents were very satisfied with the services from the mental health center, but those kids didn't improve any more than the kids who never went to the mental health center and didn't get any help. Anyways, kind of a digression. So this is just a summary of the adult literature on bipolar response. So lithium is a good medication for bipolar disorder. If you have classic bipolar disorder, about 2/3 of adult patients will respond. You might say, well, that's not very good, but this is about as good as we get with a single medication. And then if you have more of these atypical bipolar disorders, rapid cycling or cyclothymia, Depakote works better than lithium. Okay, and there are a lot of studies showing that both these medications are effective for adults with bipolar disorder. And then all atypical antipsychotic medications, and we'll talk about what those are, they have an FDA indication for acute mania at the very least. So here's, we're just going to go over the punchlines here. It's a randomized controlled trial, Depakote or divalproex in kids. This is the bottom line. The author said the results of the study do not support the use of divalproex ER in the treatment of youth with bipolar I disorder, mixed or manic state. They're just kind of looking at it. Again, you have like an improvement in both groups. This is day 28. And then there was a longer term study just keeping everyone on Depakote. It wasn't blinded at this point. And again, you see mild improvement, but the clinician said, even though there was mild improvement, these kids were still very ill. Their psychosocial functioning was still very impaired. Here's lithium. This is a little different study, so this again, try not to expose too many people to placebos. What they did was they came up with this protocol. The important thing is just start here. So 108 patients, families enrolled in the revised protocol. Only about, use this. So only less than half actually responded to the protocol. There were 40 non-responders and 23 people dropped out for whatever reason. At that point, 5 of the responders withdrew from the study saying, well, I finally found something that helped. Why would I want to have a 50% chance of having this medication stop? So that's very understandable. So then 40 were randomized to either continue on lithium. So these are people who responded to lithium. They were randomized to either stay on lithium or go to placebo. There's a problem with this slide. I just downloaded this from the electronic journal. You see that 10 plus 9 is actually 19, and 13 plus 8 is 21, so these should be switched. But the important thing was that of the 19 lithium responders, 10 of them had exacerbations or decompensated. Okay, so again, more than half of the people that responded to the lithium, it stopped working. And then the 21 then that were on placebo, 8 remained stable. So it looks like this. So again, everyone got better, then the group as a whole didn't do as well.
This was adults?
These kids.
Oh, okay.
Yeah. And so again, they conclude that lithium is not an effective treatment. It's not better than placebo. Here's oxcarbazepine. This is trileptal. It's another mood stabilizer. Again, we'll just kind of jump. So again, you see like the blue is placebo, the red is oxcarbazepine or trileptal. Again, they get better, but there's no separation. This was not a significant separation. So again, they conclude, again, the other things you can look at, it's not better than placebo for bipolar disorder in kids. Okay. So this led some, again, some might say, well, the reason they don't respond is that they don't have bipolar disorder. Another interpretation is, or hypothesis that you could generate is, these kids, because they have childhood onset, like other disorders that have onset in childhood, it's much worse. So maybe their bipolar disorder is so bad that you can't treat with just one medication. Maybe you need more than one medication. Of course, this is where we get kids on all these medications. So here was a chart review just looking at adding risperidone, an atypical antipsychotic, to kids with bipolar disorder. And so again, it's a low dose, which is good. And they found that just on chart review, and this is no control, 82% were much improved by chart language descriptions in the chart. I kind of threw this up. This is one of the earlier studies, and then I just threw it up. And then they also noted side effects of weight gain, sedation, and drooling in these kids.
Was it blind?
No, this wasn't blind. This is just starting out. So here's a randomized controlled trial. This is the one I was talking about. So Dalbello, again, fairly small. So 30 kids, they were already on Depakote, so titrated onto what would be considered a therapeutic dose of Depakote. And then they used Ativan, PRN for a few weeks to try to stabilize them further, and then, Actually, they randomized them to either Seroquel, decent dose, or placebo for 6 weeks. Okay. Now you see that half the kids that were given Seroquel dropped out. Now, in the paper, Del Bello said, well, this wasn't because of side effects. Although, you often see when you do medication placebo studies that the people on the medication side drop out more because of side effects. Or they certainly complain more of side effects. And then the placebo group, more of them completed the trial. Okay, so you got this confound of like only half the kids completed the study, though they carried their, how they were doing clinically at the time that they dropped out. They carried that out to the end. And they reported that 90% of the kids responded to the combination, and about half the kids responded to placebo. Okay. Short-term study, 6 weeks. Now, we talked about some of the non-specific effects. We'll talk about how atypical antipsychotics can be very sedating, and how much of this is just an effect from sedating that's short-term. As far as monotherapy, so the atypical antipsychotics are risperidone, quetiapine, aripiprazole, olanzapine. These are just a handful of them. There are more than this. But these are the ones with FDA approval for kids 10 to 13 years old. The first three, it's FDA approved for kids between the ages of 10 and 17 with bipolar disorder. And the last one, olanzapine, kids 13 to 17 years old. Of course, after that, then the FDA approval for adults would come into effect. And this is based on short-term studies. So you see, like the longest one was 4 weeks, and the others were 3 weeks. So when the FDA approved, well, each of these were approved separately, but there have been a group of child psychiatrists who testified before the FDA saying, well, true bipolar disorder is rare, and we're concerned that once this is approved, that just all these kids will be put on these medications. So we really need to study this more carefully. Now, at the same time, there's another group of psychiatrists looking at, well, okay, it's not what we call it. There are these aggressive kids, antipsychotic medications being used. Again, how much of this is sedating? That's a question. So they developed these treatment recommendations for antipsychotic use in aggressive youth. And in fact, whenever you read a newspaper article or watch a TV article about kids with bipolar disorder, you'll also have some psychiatrists saying, well, I had to diagnose the kid with bipolar disorder because I wanted to put the kid on an antipsychotic and I needed justification to put the kid on an antipsychotic. Again, this is done whether or not we call it bipolar disorder or not. There's a lot of just treating aggression or treating destructive behavior with antipsychotic medications. So again, for better or worse, there are people who say, well, let's at least study it. If we're going to do this, let's study it, which is a good idea. They come up with treatment recommendations. It was a combination of evidence and consensus, and they developed some treatment recommendations while more study is going on. I don't know, can you see this? I'll try to put a bigger version. Read that. So you kind of see the recommendation were things like conduct an initial eval, assess the treatment effects, so all good stuff. You do see, there's mention of psychosocial treatments. But really this is to put kids on antipsychotic medication. So this, again, just another part of the field. As far as antipsychotics then, just want to talk a little bit about this. So they do treat thought disorders. They treat true bipolar disorder. They treat true mania, but they're also sedating. So commonly you get a side effect of sedation. Again, you might be looking for that, but again, if you took it, people in this room took it, you'd say, I don't like this, I feel kind of tired. And you'd also say, I don't like this, I'm gaining some weight. So this is this one study data. So these are kids that were started on antipsychotics that had never been on antipsychotic medications before. So they all cause they all cause weight gain. And what they found is that just depending on what medication was used over an average of 11 weeks, kids gained anywhere from 10 pounds to about 19 pounds. As a result of the weight gain, going with the weight gain are dyslipidemia, so like high cholesterol. You also get glucose intolerance, which can lead to diabetes. You get muscle stiffness, sometimes a tremor. You can also get this, what's called akathisia. So this is like feelings of restlessness and feeling like you want to move. Again, not really good for a kid with disruptive behavior or a kid with irritability who's trying to sit still in the classroom. You get blurred vision. Those are the common side effects. The less common side effects are diabetes itself. There's also something called acute dystonia. And you can also get these rare but serious side effects of tardive dyskinesia, which are irreversible movement disorders, which don't go away even when the medication is stopped, and neuroleptic malignant syndrome, which is you're very ill medically, and it can actually kill you if you don't get good treatment. Again, very rare, but that most of the kids I meet and the families, that these things haven't been discussed with them. Psychosocial interventions. So again, part of the issue when you start talking about psychosocial things, the people who tend to study bipolar disorder or pediatric bipolar disorder, they're not ones who are thinking, well, what are the treatments for, interpreting it a different way? Well, this kid has behavioral and emotional dysregulation. What would treat that? Kind of like two different camps. Now, each of these are these treatments that they're all early. They tend to be kid and parent interventions. They're fairly non-specific. If you looked at what they do, you'd say, well, this is like a treatment for emotional dysregulation, or this is a treatment for disruptive behavior. And they're good things. Don't get me wrong. That they have to do with helping the kid to identify the feelings, working on other skills, working on parenting skills to shape the behavior of the kid. And so these. Not all of these have been tested like in randomized controlled trials, but this is at least most of these people are attached with the group that's studying pediatric bipolar disorder and offering this as a psychosocial intervention. So where are we today? One article from New England Journal of Medicine. Is there a dramatic increase in the number of kids diagnosed with bipolar disorder appropriate? The answer seems to be no. Rather, the dispute has been about whether bipolar disorder is the right diagnostic home. Talk about what that means. Leibenluft is saying, the published data suggests that kids with severe non-episodic irritability do not suffer from bipolar disorder, at least as it is classically defined. And then, again, she's a proponent of severe mood disorder. She's saying, well, we've got to study this. If we're going to study this, we better study treatment, because if we're going to create these things, create these diagnoses, part of science is trying to describe, explain, control and improve and predict what's going to happen. And so with the bipolar disorder, pediatric bipolar disorder, you see that these kids were diagnosed with this, but we didn't do so well on some of these other aspects of science, like improving and predicting what was going to happen. And the same would be true of severe mood disorder. So DSM-5, there are a number of proposals. Who knows? This is just what is being proposed right now, and DSM-5 is still being constructed. It's an idea that to require mania or hypomania to be present most of the day is contrasted with a series of brief tantrums or periods of irritability adding up to 1 to 4 hours a day. And then really emphasizing that these manic episodes are episodes, that it's episodic, there's a beginning and there's an end, and that it's a change from baseline. So again, this language is in DSM, but to really emphasize that so that this chronic irritability doesn't get lumped in with bipolar disorder. Then more controversial is, also controversial, is this diagnosis of temper dysregulation disorder with dysphoria. People heard of this, TDD. It's based on SMD, severe mood dysregulation. So again, one of the critiques would be, well, this hasn't really been studied very much. Only one group has really done a lot of research in severe mood dysregulation. Again, the criteria will change. I can't say I'm crazy about the name either. It come up with something better than temper dysregulation. And so again, there's this question of, is there a diagnostic home for what these kids, how they should be classified? So some people say, well, we diagnose all these kids with pediatric bipolar disorder because there's no place in DSM-4 to put them. And I don't know if that's true, but that's part of the rationale. And then if we gave them a home other than bipolar disorder, if we just called them something else like TDD, then maybe they wouldn't be put on these medications. Now, I'm not sure if that's true either. But I suppose that it is helpful to say these kids don't have bipolar disorder. I mean, that would, I think when parents hear about bipolar disorder, they they tend to think of adult bipolar disorder and what they know about that. And really, the evidence suggests that we can't generalize what we know about adult bipolar disorder to these kids with pediatric bipolar disorder. And then, what are the consequences of creating a diagnosis prematurely? So without a lot of research, again, we can't explain, control, predict, what's going to happen with all this. And think of the forensic aspects of this. Like, so if you have all these kids diagnosed with this, then how does this, how would this assist in a defense in juvenile court, for instance? And we can also look to how's the rest of the world dealing with this. I mean, it's again going to be something that we do in the United States, but not the rest of the world. These are just kind of my opinions more than anything else. Not just my opinions. Other people mentioned this as well. So again, the idea is it's just this hole that we need to diagnose kids. That, we need to create this new diagnosis. Or does it look more like this, where, wow, there are these other diagnoses that could be used, but psychiatrists aren't careful enough to try to diagnose appropriately. Another approach has been using explosive anger as a modifier for DSM. Again, I don't like the term explosive anger, but to modify something like, okay, well, since all these kids had ADHD, maybe more appropriate would be ADHD with emotional and behavioral dysregulation, for instance, and that you could add this modifier to other diagnoses, so conduct disorder with explosive anger. Sounds like this isn't going to go over well, but there actually would be some advantages to this. And then kind of along with these Trey researchers, this idea of, well, yes, you have this problem of impulsive aggression. It probably isn't its own diagnosis, but you see in multiple diagnoses. And so let's study this as a construct. Conclusions then, I guess I didn't talk too fast. I'm surprised I actually finished on time. The construct of pediatric bipolar disorder is very controversial, but regardless of what we call these kids, they have a lot of needs, and we do need to get better at helping them. Really, there's no reason to generalize what we know about adults with bipolar disorder to generalize that to kids being diagnosed with pediatric bipolar disorder. That the course isn't the same, the response to medications isn't the same, and the things that will help aren't the same. And what diagnoses or what challenges the kids will have as they grow up aren't the same as adult bipolar disorder. There's really little or no evidence to support the idea that these kids being diagnosed with bipolar disorder will grow up to have adult bipolar disorder. Again, the meds are different. The antipsychotics can sedate, but that's fairly nonspecific, and we don't really have any long-term studies. And the psychosocial interventions that are being developed are fairly nonspecific. And as you see, a number of the people in the field are now moving beyond DSM-5. Looks like it's going to move beyond diagnosing kids with pediatric bipolar disorder, but we do need to get better classifying and diagnosing kids if we're going to help them. So with that, I'll ask if there are any questions. Yes?
These kids who were diagnosed with bipolar disorder, I don't remember if you said this, did they present with sleep disturbance?
They'll complain of sleep problems, but like staying up all night, that's not something that they have. Yes?
Don't you think that the messiness in characterizing this and finding clear patterns probably speaks to the need to better describe the kids' proximate social environment, parents, and that might be the unmeasured variable that would have a lot of explanatory value.
No, so certainly seeing these kids in a context, either in trying to diagnose them or try to help them, that I think is the way to go. As I say, the folks who tended to do this or treat with medications weren't, always thinking of these things. Right. Yes.
In other countries, do they use the DSM, or do they have some sort of manual to classify conditions that is different from what we use?
The ICD-10 International Classification of Disease tends to be used in other countries, in other westernized countries. And so that they have criteria that are similar but not exactly the same as bipolar disorder. That doesn't account for all the differences in why bipolar disorder is diagnosed so much in kids. Yeah. Actually, another explanation has been that we put more kids on psychiatric medications so that they were causing their symptoms to come out. I don't think that's a good explanation either, or even if that were the cause, that would just argue more for not putting kids on medications unless they really need it. Yes?
I really appreciate you sort of debunking the notion that we have all these bipolar kids these days, because I absolutely agree that that's really a misuse of the DSM, and it isn't helping
Right.
in terms of trying to work with these kids and these families. Can you just speak briefly about what you would say? You've got a kid with severe behavior dysregulation, you've got all the stuff that's getting labeled bipolar. What do you think we ought to be doing with that?
Yeah, well, I think we ought to be looking at the context in which these kids reside and providing psychosocial interventions. So again, we know that there are things that work for anger control in kids. We know that there are things that parents can do to shape their kids' behavior to be less disruptive and less irritable. Actually, going along with this, I was reviewing another study looking at preschool kids on antipsychotic medications. So again, we've got this great increase in preschool kids being put on antipsychotic medications. So Marcus Olson was reporting on this. He actually looks at a lot of these studies of large databases. And these were kids with private insurance. Okay? These are all kids with private insurance being put on preschoolers being put on antipsychotic medication, and only about 40% of them had had a psychiatric evaluation. Only 40% of them had had psychotherapy, or a psychosocial intervention over the year that they were on this insurance panel. So there's a lot more that we can be doing before we start putting kids on these medications.
Yeah, I think there's a real tendency in our country today to look for the quick fix, and many of the parents and family members and the natural supports are looking for a medication or something so they don't have to deal with the problem. And I really, that's the wrong way to go.
Right. I mean, there's the quick fix. There's also, say you had a parent that said, okay, I want these other effective treatments for, anger control or for disruptive behavior. There's also not great access to effective treatments for disruptive behavior. I mean, that's part of why we want to have this seminar series, is to try to promote at least interest in adoption of effective treatments for all psychiatric disorders in kids. Yes.
I used to listen to treat poor kids, and now I'm listening to treat wealthy ones with relatively with insurance. And parents, it takes them 3 or 4 months to find a clinician who's probably not really all that well qualified to treat what kids have. And these are kids with a lot of resources.
Right. Yeah. Again, there's a shortage there's a problem with access, and unfortunately this leads to things like pediatric bipolar disorder and the use of medications. Yeah.
So you touched on this, but you said that pediatric bipolar does not lead to a classic adult bipolar, and you said some of the things that it has shown is increase in sort of the access to antisocial and borderline personality disorder. Is that for kids that have been treated with maybe psychosocial treatments and have still developed some access to, and do they meet full criteria, or those are untreated kids? Can you talk more about that?
Yeah. So you're referring to a study a slide that I put up by Lewinson. So again, this is like a naturalistic study, and the kids got whatever help that they got over time. I mean, based again on this discussion, you know that probably a lot of these kids didn't have access, probably didn't receive effective treatments for like disruptive behavior. Because that would really be the exception, that someone would receive an effective treatment. Okay, well with that, I'll thank you all for coming.